Thank you so much for that, Dr. Smith. I've just launched the poll, so I'm going to give people a couple of minutes. And Dr. Fernandez, I'll hand over to you for any comments or questions that you may have seen.
Yeah, thank you so much. That was great. I know that it's a lot of information for folks, and we on the schedule we had that we were going to do questions, address questions and answers after my talk, but I think that it would probably be useful to go ahead and do any questions that you might have from this presentation now while it's fresh in your mind. So I know that there's Sidra, I'm not sure how many questions there are. I know that there's been a few that have been answered.
Yeah, I think a lot of the questions that were coming through the Q&A, the panelists efficiently answered them. So we don't have any open at the moment, but I was just wondering if Dr. Fernandez, if you thought there was anything that Dr. Smith should expand on a little bit that would be useful to our participants.
And there's so much there. I mean, there's not really anything in particular unless somebody, I guess one of the questions that I often get asked, JD, is more related to in those situations where you actually might not have a lot of different clinics or organizational units to use a randomized design, and any advice that you have about that. That's one. And then another that I think has come up is when you actually may have many units, but they could be quite different from each other. Any particular approaches to think about when there is a possibility of doing a randomized design, but you know that there is some heterogeneity in those units. Those are, I guess, two questions that often come up.
Sure. So let me try to answer the first one with kind of the small number of units issue. Using interrupted time series and potentially other kinds of designs that are specifically meant for N of 1 or really small N designs is one option. Another option is if you have, let's say you have a health system, and really it's a health system intervention. So that's your effective unit, and you have an effective N of 1. There are ways to potentially test strategies at like the provider level where you could randomize those providers or at least compare implementation strategies there. You're likely in those situations to have system level strategies that really can't be tested, or maybe could be tested using a pre-post. But in terms of actually having a fully powered test, you may be able to vary the implementation strategies that clinicians get or that teams get as a way to increase the number of units within a larger N of 1. We do see that fairly commonly. It does get a little bit difficult sometimes when you do have strategies being tested or strategies being used at multiple levels, but really only able to effectively test the comparison at one level. So that is one drawback, but is a way to potentially get power and answer a slightly different research question. The other one, yeah, that's a good question. So when you do have heterogeneity, one of the things you can do is similar kinds of randomization schemes that use weighted covariates. Matched pair examples are really good because they can basically match up similar studies and then randomly assign each of the pairs to which conditions. And so you balance across conditions, despite the fact that within the condition, there's quite a bit of heterogeneity. That does tend to increase your interclass or intercluster correlation coefficient. And so that would have to be dealt with within your power analysis. But that is less of an issue typically in power than the just difference in ICC between the comparison and experimental condition. That's the one that's going to drive the majority of your power. The within cluster correlation coefficient, has a lesser of an impact on power, but still typically needs to be considered.
Thank you, Dr. Smith. Dr. Zhu, I think you had a question.
Yeah, thank you, Sidra. Thank you, Dr. Smith. I think it's excellent presentation. It's actually, I recall there is a question yesterday from one of the participants asked, some countries, for example, there is resistance in terms of receiving integrated care which is you put a multiple level intervention together, maybe through even multiple implementation strategy. And that question asks, if there's resistance, what do you do? So when I thought about it, I thought it's almost like a research question to you, like today, if there is resistance, what do you do? Can you design sort of like this is trial? One is related to innovative integrated care versus business as usual. Nobody want to change. And
Sure.
what do you take this question?
That's a really good question. I think unfortunately what typically happens is we're focused on getting our N to be able to design our study and carry it out. And so we often overlook those, they're just basically not eligible, or they become ineligible because they decline. So there are some research studies out there that kind of look at this issue from a re-aim perspective, for example, where you don't just talk about, like, the study question itself becomes who is interested, what is the degree of interest and acceptability of this potential delivery model that kind of gets expressed within your adoption metrics. That doesn't help you actually get to doing the study design, but it does give you a sense of what is the likelihood that someone would ever adopt this, that it would have large scale adoption if our trial is effective. But yeah, I think that one of the problems is that we tend to approach lots of sites. If they say, I'm not interested, we just kind of document that there was a site approach and they decline, but we just keep going until we get the N that we need to power our study. So yeah, that's a great actual research question in and of itself, is to really understand why certain sites might be resistant to certain delivery models. And we have seen that actually in some of the work that I've done, which is trying to get primary care providers to prescribe pre-exposure prophylaxis for HIV. They often feel like patients should go to specialty HIV and STD clinics, where folks really do focus on that outcome and can be more familiar with like the PrEP guidelines. So that was more at the provider level. And also the patients don't necessarily want to go to their PCP to actually get HIV care. So there is reasons to potentially look at the pull and look at the acceptability from both the system and from patients about where do they want to get care, what kind of care do certain systems want to deliver, and then to build that into your almost like testing a recruitment strategy, or at least documenting clearly what happens when you approach different sites if there is likely to be some resistance or a high degree of declines to participate.
Thank you.
Yeah,
I would
really good
just
question.
Yeah, it's a great question. And I would just add a couple comments to that. So I think it is important to think about whether we're talking about adoption and implementation of a particular approach or integrated care approach or particular intervention and participating in a research study, right? So those are really sort of distinct things. And I think you were talking about, when you asked the question, you were talking about sort of use or adoption of a particular system. I think that obviously, in order to do a research study about implementation of a new innovation or an integrated system of care, there has to be some buy-in to actually adopt it and use it. Yesterday, we talked a little bit about what's the distinction between implementation research and dissemination research. In implementation research, typically, you have some buy-in already that they're going to at least attempt to implement something. And you're really studying the processes, the effectiveness, the impact of strategies to help improve that implementation. In dissemination research, you're really backing up and you're saying, what would make organizations adopt a new intervention or care pathway? And I think that those are different questions, but the approach, the process that you would use to develop strategies to influence one or the others, the process is similar. And I'm going to talk a little bit about that in the next talk, in planning strategies for influencing adoption, for influencing implementation. Yeah.
Yeah, great distinction.
Other questions?
I think you guys have addressed everything. And Dr. Fernandez, if you'd like to, whenever you're ready, to take over for your next presentation.
Okay. And JD, you are welcome to stay, but also, since we've already addressed questions from your talk, if you don't want to, you don't have to.
I will
Thank you.
probably stay on to listen to your talk, and then I might have to jet to get to my conference responsibilities.
Right. I know
see, sorry, I see 2 hands from participants before, and then I don't know if their colleagues want to ask a question or not.
So we had I guess one question has, no, one question has just come through. I did see the hands raised, but we're taking questions through the Q&A box. We're not enabling the mic for the participants at this time. But I've just seen one question come through, which was, when looking into aspects of acceptability and appropriateness of an intervention, an issue that often comes up is trust on the system, and an assessment of the determinants of that trust may be crucial to understanding the context. What sort of a framework would be most appropriate in this scenario? So I can open it up if somebody wants to answer the question, or we can type up an answer to this question later on.
I don't have a great example. Some of the actual health equity frameworks for implementation research now are talking more about, historical factors like racism, trust in medical care in general. So there's a couple probably that do have at least some constructs that would be interesting to look at. But yeah, there's 2 or 3 recent health equity implementation research frameworks that I would take a look at, and maybe we can share some of those links.
Thank you. Dr. Fernandez,
I'm sorry, I was trying to look up the question. Sidra, can you ask that question again?
Yeah, sure.
The sound cut out for me for a moment.
The one that Dr. Smith just addressed? Yeah, it said, when looking into aspects of acceptability and appropriateness of an intervention, an issue that often comes up is trust on the system, and an assessment of the determinants of that trust may be crucial to understanding the context. What sort of a framework would be most appropriate in this scenario?
So my response is that it depends on who you're talking about. If you're talking about trust from the perspective of the patients or the community members, and why they may or may not engage with a particular intervention, and whether or not that intervention is appropriate for them based on trust, or more likely, how you might have to adapt that intervention to address issues of trust, then you're talking about an adaptation scenario. And I would point you to the direction of frameworks for adaptation. Yesterday, I participated right after our training in a workshop that was sponsored by University of California, San Francisco, on adaptation. And it was a fantastic workshop, and it included a section on cultural adaptation and issues of working with immigrant populations. And so what I can do is I can see if the recordings from that can be available, and we will share it with participants, because I think you will really like that. But getting back to the question, so if you're talking about trust, so that I gave the example of if you're talking about trust from the perspective of the sort of the priority population. But then if you're talking about trust of those individuals that are responsible for adopting and implementing a particular innovation, then I think that some of the frameworks that we currently have can actually be really helpful, because they do address some of those issues on the personal level of the adopters, and characteristics of the adopters, and perceptions that they might have of the innovation itself, but also of other factors, including things that we would consider in the outer setting, right? The system is probably the outer setting, and how that might influence implementation. But there are things that would come up during that identification of barriers and facilitators that we talked about earlier today. And those would be documented and then hopefully addressed with your implementation strategy. So one of the things that I'll be talking about now shortly is when we're thinking about the development of implementation strategies, we have to remember that implementers are people too, and implementers have attitudes and knowledge and capacities, and sometimes mistrust in their own system, mistrust in the broader system. And those are very important things to consider and take into account when we're developing strategies, so that we can address that. But it certainly is a big barrier if that does come up.
We actually have a real example from our case study to say that patients do not want to go to the certain health center, even the health center can provide a service, because the perceived quality of those lower level health facility, for them, it's basically they don't trust. They think the quality provided by lower health provider compared to the same service provided by specialist is lower. So that kind of thing, affect the utilization of the service at those basic primary health care level.
And when you're doing implementation research, these sorts of things come up where that have to do with the patient's behavior. And when it does come up, that's falling a little bit outside of what we typically think about as implementation research, unless you're talking about adapting the intervention. So if you have an intervention, for example, and it doesn't address these real concerns that patients have about, going to the health centers or other issues that they might be having, then that means that you have to adapt that intervention. If you try to, even if that intervention is implemented exactly with fidelity, if it doesn't address the main barriers and issues related to the patients, then it's not going to be effective. And so, but that I would put in the category of adapting the intervention for patients, not so much in the category of planning its implementation. Okay, I know this is something that a lot of times we sort of get confused about, and we're thinking about, well, what part is intervention and adaptation and what part is implementing or delivery, but all very important and all an important part of implementation science. One of the Don reminded me that one of the tools that I'm actually not going to have too much time to talk about today, but I did talk about yesterday in the lecture that I was giving at the workshop on adaptation that hopefully we can share with you, is that we have a tool that we've developed called IAmAdapt, and it's an online tool to help people find and also adapt evidence-based interventions. And it sort of walks you through this process of considering what are the needs in the population, and how we might be able to make some decisions about adaptation when we compare the intervention that was already developed and the needs in the population. So we can talk more about that. I see that Don has shared the URL to the tool. I will tell you that we're currently working on the tool. We're sort of revising it and fixing it. So if you are going to access it, that's fine, you can. But if you have any issues with it in the next few weeks, it may be because we're working on it. And I would encourage you to go back in a little bit later.